Hello, everybody, and welcome to our revenue cycle 101, how denials and deductions originate and impact your health system. We're very happy to have Ryan O'Hara with us today. And just in case you need the phone numbers, the access code, they are right there on the first page. So let's get going. There's a lot to cover. I guess I should introduce myself. My name is Carla Haravi, and I'm the president of ADAM and senior vice president of clinical resources at PayerWatch, and very happy to be here. So what you're seeing right now is a control panel, and if you take a look at it, it tells you how to join the audio, how to open and close the control panel, where you can download handouts. And the handouts are ready for you. You can download them at any point in time. And then down below, there is a place where you can submit questions, you can submit comments, and what we'll do, we're going to save the questions until the end, but we will do then our best to get as many questions answered as possible at the end of the webinar. And we will also, for any that were unanswered, we will do our best to collect them and then post them on the ADAM website whenever the webinar is posted, which would probably be in a couple of weeks. Okay, so a little bit about ADAM. ADAM is the Association for Healthcare Denial and Appeal Management. It's the nation's only association dedicated to healthcare denial and appeal management. Our mission is to support and promote professionals like you working in the field of healthcare insurance, denial and appeal management through education and collaboration. Our vision is to create an even playing field where patients and healthcare providers are successful in persuading medical insurers to make proper payment decisions. If you'd like to learn more about ADAM, our organization, you have the website there, and ADAM was created through the very generous support of PayerWatch. So just a little bit about PayerWatch. There are two different parts to PayerWatch right now. PayerWatch Appeal Masters, that is the side that writes appeals, and we train folks, and thousands have been trained in denial and appeal management. We strongly believe in taking your appeals all the way as far as you can possibly go, and we also believe in taking a clinical legal approach as well. Now, PayerWatch Veracity. Veracity is the software that helps in the denial prevention industry, and it was created to be in service to providers in protecting revenue. So if you'd like to know a little bit more about PayerWatch, the website is there. So, well, I'm happy to introduce Ryan O'Hara to you. He is the managing principal of Denial Research Group. And Ryan is a very accomplished healthcare executive with a wealth of experience in revenue cycle operations. Throughout his 20-plus year career, Ryan has demonstrated a deep understanding of the complexities of healthcare financial management, has worked to develop strategies and solutions to drive efficiency, reduce costs, and improve patient outcomes. The majority of his time has been spent in the healthcare provider side, working as a revenue cycle operations leader across many hospitals and health systems. He has also spent several years working on the EMR and third-party business partner side. So this has provided Ryan with a diverse and a well-rounded background, but one that's always rooted in being a trusted and value-add contributor for healthcare providers. And I think that's why we're all here. We want to support our healthcare providers and the hospitals. So very happy to have Ryan here. Now, there are a bunch of slides that I have to go through, so bear with me. So a little bit about the CEUs and the contact hours. As always, the webinars, the education is free to anybody. It's complimentary, but to get CEUs, you must be a member of ADAM. So to obtain CEUs, you must be an ADAM member. You must attend the live webinar for at least 53 minutes. Physicians, to get CMEs, you have to attend the entire presentation. And you must complete the survey that will pop up automatically at the end of the webinar. Now, CEU certificates will be emailed to you generally within a week of the webinar. CEUs are not available for watching the recording. And a disclosure, no individuals in a position to control content for this activity have any relevant financial relationships to declare. Now, I must tell you, due to some unforeseen circumstances, we're not able to offer all the CEUs that we normally do. So, the ones that are listed here are the ones that we are able to offer for this webinar. So you can, whatever applies to you, you can select as many as you want. A Medco, these are CMEs for physicians. ACTUS for CCDSs, NARI, Certification in Healthcare Revenue Integrity, and nurses through the ANCC and the NEMSD. So there are about 3 slides here for the physicians in the audience. I am not going to read all of them, but I do ask that you read them and understand the information that is in them. We're required to show this to you. Disclosure of conflict of interest. There's a table here, and there is no conflict of interest to declare. Now on page 10, please note this tells you how to get your certificate, and this again, it applies to physicians who want CMEs, a CME for this. Hope you can join us for our next complimentary webinar. Upcoming one in September is about winning appeal language. It's going to be a good one. It's something that you folks have asked for. Those of you who've been here before, you know that's always something that we ask in the survey at the end. We want to give you what you want. This is something that a lot of people have been asking about. So I think it's going to be very educational. It's going to be tailored for new appeal writers, but also for not so new writers who might need a refresher. So registration is open, and then again, CEUs for ADAM members only, but anybody can attend. All right, and with that, I'm going to turn it over to Ryan. And Ryan, just let me know when you're ready for me to go to the next slide.
Yeah, thank you, Carla. Welcome, everyone. Thank you for giving us an hour of your time. I know it's valuable. This is going to be pretty high level today. One of the things as agenda topics had kind of come up is this idea of clinicians understanding revenue cycle a little bit more. I know that's the majority of our audience here today. So if any of this feels dumbed down, know that it's called Revenue Cycle 101 for a reason, and that we want to make sure that we're hitting on this kind of idea of denials and deductions at a very, very high level. But as always, I love talking shop with anyone. Feel free to reach out to me when we're done. I'd love to set up time to just talk more if you have any other questions that we don't get answered today. So some of this is universal revenue cycle stuff. Some of this is very akin and personal to kind of just my opinion. So I should probably preface everything by saying some of this is the way I think, and some of this is the way that revenue cycle operators in general think. And there'll be a little bit of a merging of both. But when I think of the primary revenue cycle objective, especially from like a CFO's or a financial perspective, it's to collect the appropriate reimbursement for service provided without delay. We want to get paid quickly and right, and we want to do that at the lowest possible cost. And I think that's a part that some people don't think about. It is very, very important. Margins are thin in healthcare. I've spent the majority of my time on the healthcare provider side, and it's important that revenue cycle be good stewards. And so when I say everything that I want to accomplish and everything I want to do, it's almost ... at the lowest possible cost. Not to be skimpy, not to be tight, but to do it in the most efficient and effective way possible. And really the best way you do that is medical record integrity. The quickest way to get paid appropriately and timely for services rendered is to have a medical record that's airtight, that we can defend, because it's the only thing we really have once payers come back and say, we're not going to pay you for this, is the integrity of that record. So kind of how do we do this? We get the right clinical outcome at the lowest possible cost, appropriate resource consumption, cost of care management, accurate patient status and continuum of care plan, getting them out at the right time, getting the documentation coordinated really, really well, and making sure that when we discharge that patient, they are being discharged to the appropriate environment, and that they have met all the markers to be appropriately discharged. Medical record integrity at the lowest possible cost. I already kind of hit on that one. And then turn AR into cash at the lowest possible cost. How do we do this? We send out claims that aren't missing modifiers or that encompass all the information. And it's a crazy amount of information that a payer is asking for when we send out that claim. That's what a clean claim means to me, is I have checked all the boxes that I possibly can to say that you, with the most reasonable interpretation, are not going to deny this. And then making sure that when they do deny it, that we have a denials management process in place that says we know how to timely identify stuff that's winnable. We know how to timely identify how we're going to attack the stuff that's winnable. And we're going to do that in a clinically researched and a legally researched way. One of the things that I see in denials management at just a very high level is this reverse order gross charges by payer, and then we work them. And what happens with that is gross charges and net charges aren't always correlated. Oftentimes they are, but they're really often not as well. And it's to say that if I'm going to queue up an account that I want to work, I would rather my follow-up rep not have to spend 45 minutes in the record, 45 minutes trying to research and figure out. So denials management, what I mean by that is smart work queue, smart content, fight what you can win, don't fight what you can. And that's hard when there might be a $200,000 account out there that's unwinnable. And it's hard to write that off, I get it. But it's also harder to spend hours and hours of man and woman hours to try to overturn something that was never going to be overturned in the first place. So that's what I kind of mean by denials management. Next slide, Carla. So I'm going to just quickly go through this. This is just a summary report from last year that said, from HFMA, indicating that 19% of all revenue cycle time is spent on denials. That's not back-end time. That is front-end, mid-cycle, nurse auditors, physician advisors, UR, if that falls under. This is 19% of all time amongst all employees is spent on denials. Half of that time in the back-end is spent on denials. So you can literally look at it and say 1 out of every 2 of my people working in the PFS office, or the back end of the revenue cycle, as we call it, is spending their time working on denials. We're currently at a 13% first pass denial rate, and that's only going up. And this one actually, I gotta believe HFMA didn't phrase this question right, because 31% of organizations are focused on denial prevention. I gotta believe it's way higher than that, or maybe it was phrased as what's the most important thing you're focused on right now, which is denial prevention. But that leakage is so important. Next slide, Carla. So I quickly want to talk about kind of technical denials and how that differentiates from kind of administrative and clinical denials. And then we'll talk about all three quickly, and then we'll get into more of the meat of this presentation. So they're typically not related to appropriateness of care or necessity, but they're kind of something was submitted and it gave insurance a door that they could open and say, we're going to deny you. These are often like incorrect patient identifiers. It might be a transposed MRN. It might be their address is 1 number off. This is a real story. I had a denial one time in my life where they denied it because ST period was the street and they had it as STREET. They're both street, but one is ST period and one is street. And that was what we figured out was what they were denying for. Incorrect identifiers, timely filing, incorrect authorization or lack of authorization. But it's traditional kind of administrative back office stuff where the claim got out the door through the scrubber and something kind of technical or very kind of clerical was missing. Next slide, Carla. So now these are kind of getting commingled sometimes with lack of coverage, insufficient insurance verification. And while most of these kind of come through the EOB, through the form of CARCs and RARCs, the problem is those CARCs and RARCs are not, there's no standard of use that's been dictated by any organization that says Humana might call this a 252, but Aetna might call it I don't know, a 31 or something, whatever. It's just to say that these CARCs and RARCs, which are supposed to be universal kind of definitive reasons as to why a claim was denied, are not very universal. And that does create a big problem, and it's part of denials management is how do we kind of sort and sift through this stuff to figure out exactly how and what we're fighting, and if we should in fact fight it. And then lastly, deductions aren't standardly used. Deductions are internally, inside the four walls of a hospital or a health system. Deductions typically consist of 5 things. It's contractuals, it's denials, it's financial assistance, it's bad debt, and it's administrative. Contractuals being the biggest of these. Contractuals is the biggest, by far, deduction in healthcare. This is I charged, for easy math, $1,000, but insurance is only going to pay me $200. That other $800 becomes a contractual. Everything after a contractual is made up of denials, financial assistance, bad debt, administrative. And we'll go through that in a little more detail here in some of the coming slides. Go ahead, Carla. All right, so this slide here is what is gross revenue? So that's kind of the first thing we want to talk about. Think of gross revenue as charges. You know, hey, we billed out $200,000. We're going to get $200,000. No, we're not getting anywhere close to $200,000. And depending on the payer, there could be a truly $200,000 swing in what we got paid, but from probably good commercial to, let's call it Medicaid, state Medicaid, that difference is probably on average $100,000 to $120,000. That's a difference between gross revenue and what we expect to actually get paid. So that's what we're going to call net revenue. So I charged $100,000. My contractual write-off is $100,000. My net revenue is now $100,000. That's the best I can possibly get because insurance is never going to pay me more than they're contractually allowed out of the goodness of their heart. So then there is what is cash. Cash, the difference between gross revenue, what we charge, net revenue, what we expect, and cash is actually what we get. And net revenue and cash are aligned a lot, but they're not always. And it's those other 4 deductions that fall in between net revenue and cash. And if you take that and divide it by expenses, right? We got the cash that came in through the door. We'll take investments out of this because we're going to call this operating revenue, not total revenue. But if you divide that by expenses, what you've got is operating margin, right? So there is a margin that exists outside of hospitals as well that includes of investments and other things that go on. But when we talk about operating margin, and you can go ahead and proceed, Carla, what we're talking about is cash over expenses. And the way I like to think about it is this little thing on the right, which is if you look at your own paycheck, your gross is kind of that, hey, here's what my salary or my wages are. What I bring home is kind of that deduction down to net. And then there's expenses that get taken out in terms of what I spend. And so if you think about it in terms of kind of your own paycheck, to me, it's a little bit easier to kind of follow gross, net, cash, expenses, margin. But really think of it as gross is what we charge, net is what we expect to get, cash is what we actually get. Okay. All right, we can go to the next slide. All right, so here's just kind of a real life example that I'm going to give you with kind of easy math. And this is, we're going to start with $1 billion of gross revenue. And $1 billion of gross revenue makes you kind of a medium-sized health system in this day and age. So if we start out with gross revenue of $1 billion, you can go ahead and click forward on that, Carla. And then we do some sort of very reasonable amalgamation of overall contractuals, inclusive of all of our payers, what we expect to pay, then a very reasonable estimate of gross to net for most health systems in the United States is we've now gone down to 400 million. Charged $1 billion, the best we can get is 400 million. And then there's all this administrative, the other deductions I talked about, denials, bad debt, charity, and administrative adjustments, that in a well-run operation are going to equal approximately, let's call it 380 million of cash. And that's a pretty well-run organization with only 20 million of deductions, or approximately 5%. So let's go to the next slide real quick, because I want to get into kind of a deeper conversation on payer mix and its impact, because I think it's an area, when I talk to clinicians a lot, there's a lot of like, wait, what? This makes this big of an impact? So the math I used on the previous slide is based off of kind of this generic slide I made up here. And this is a reasonable payer mix for any hospital USA. Some places are going to have higher commercial. And when I say commercial, I'm talking Blue Cross and commercial. It typically gets its own bucket because of its size. Some places might be 40+% commercial and even lower than 60% government. And by government, I mean Medicaid and Medicare. And you can now kind of mingle managed Medicare in there as well. But this is just a kind of a generic example of how I got to that 380 million on the previous slide. And if Kristen, if you can give me control, I just want to kind of maybe show this in a little bit more of an interactive way, if I can. Okay. So I'm going to show something to the group, and I apologize if this is a little bit messy. I hope everyone can see what I'm showing at this point. But you should recognize this and this from the slide we just looked at. This is that payer mix. One of the things I wanted to point out is if you take this kind of reimbursement percentage, it averages out to 35.5%. But our actual gross to net is closer to 38%, because we've got commercial payers that pay more. They make up a bigger percent of the population. But if we take this right here, this 1 billion of gross, and we apply this across these payers, we get roughly 380 million of cash. Now, I would love this to be audience participatory, but I think we have a few hundred or so folks on here. So I'm just going to do this on my own. And what I want you to watch is this green number right here and this number above it. And this is meant to just kind of give you reference back to this, because I'm going to change these numbers, but this is what I'm changing is this over here. So let's just say, and this is very, very, very likely that this kind of stuff happens. Let's just say that you're in a community and a large employer left town, and you saw a 2% decrease in commercial and a 2% increase in uninsured. The cash impact of that is $13 million. That is over $1 million a month impact to a place that's probably operating on pretty slim, if not some months, negative margins. This is the importance of payer mix. So let's just say we didn't get hit quite as badly, and it didn't all go to, we didn't have a shift straight from commercial to uninsured, but let's just say that the economy slips a little bit, and we now start to see maybe an increase in Medicaid. Let's say Medicaid moves by 3%, we lose 1% on Blue Cross, we lose 2% on commercial, we've now just lost $16 million. And that's assuming revenue stays the same, costs stay the same, everything kind of stays net neutral other than just shifts in payer mix. This is so important, and it's why folks like me keep such a close eye on payer mix, because it has such an enormous impact in terms of what net revenue is, what we could possibly get. So when you have $1 billion of gross charges and 400 million in net, that 400 million can move to 380 in the blink of an eye just by some sort of small shift in payer mix. Now, conversely, there is no patient No patient that's more important than any other patient, but from a revenue cycle operation standpoint, there are payers that we have to watch with an eagle eye. And when I say that, it's mostly Medicare and our commercial population. So conversely to those kind of negative scenarios that we were talking about earlier, let me get this back to 10 so we can get even up. Let's just say we saw a 1% increase in Blue Cross, and let's say it came at the expense of our uninsured, our self-pay population. Well, we just gained $6 million. That's a 1%. That's a 1% increase in just Blue Cross. One payer probably happens to be, for most markets, the biggest commercial payer, but a little 1% shift there is a $6 million difference. The reason I wanted to spend time on that is a lot of times when I talk to folks, the impact and the variability in payer mix, and sometimes you'll see this even month over month. There was an example I have from my past where I used to be chief revenue officer for a health system that sat on the corner of the largest Native American reservation in the country, and so we saw an inordinately high amount of Indian Health Services (IHS) patients than maybe some hospital in urban New York, let's say. And we had the flu. There was it was a really bad flu season. And so we had actually an influx of IHS patients occupying inpatient beds with the flu. Now that doesn't reimburse good. IHS doesn't pay very well, but they were taking up an inordinately high number of utilization beds in our system. And we had gross revenue off the charts that month, but our net revenue plummeted. And it's meant to say there's a corresponding difference between charges and what we expect to get. And that is primarily driven by payer mix. Payer mix is the number one kind of influencer of my gross to net calculation. And so keeping an eye on that is incredibly, incredibly important from a revenue cycle standpoint. Kristen, you can take control back now, or I will stop here. And I hope everybody was able to see that. Okay, we can go to the next slide. I want to go into kind of a real life case study. And again, I've blinded all the critical information as it relates to this particular client. Actually, go ahead and just hit, you can, I don't need these to show up animated, Carla, if you want to just hit it 4 times. Yeah, might be a little bit more than 4. So yeah, there we go. Thank you. So this is a real life, real health system case study. They had seen gross revenue increase by 11.5% or $201.2 million. Key drivers, volume and rate increases. Net patient revenue had increased by 5.3%. So you can already see, right, that net is going to lag as related to gross. So 32 million of an increase of 201 million net. Key drivers, payer mix changes, and rate increases do not even add up to net revenue increases for a lot of payers. Dirty little secret is rate increases really only impact your commercial population. Medicare, Medicaid are going to pay you what they're going to pay you, and you can increase your rates as much as you want. It really only affects those contracts where you've got language in there that kind of thing affects, and that's your commercial population. And that's why, as a revenue cycle leader, I say there's no more important patient than any other patient, but there are payers that we have to keep our eye on and are essentially more important for us to keep our eye on, and commercial leads that list. Other operating revenue, there was a decrease in 5.3 million. Again, other operating revenue is investments and things like that. This one, there was a key driver in that their retail pharmacy had seen a change, and a lot of that was around 501c or whatever. Sorry, I can't think of the name of it right now, but the government reimbursement on pharmacy. Expenses had increased by 8.5%, or 49.2 million. Key drivers there: salary and wages had went up by 21 million, benefits correspondingly go with salaries and wages, so they went up by 5 million. Supplies had increased, professional fees, and depreciation. So what they saw was an operating on $201 million of increased gross revenue. They saw their operating margin get cut in half. And the key driver of that, as I delivered to them, was the cost of care is rapidly outpacing your net revenue growth, even though you've seen volume and rate increases. And there's a visual of that on the next page if you'll go there, Carla. So what we've got on the top there is net revenue in orange. We've got expenses in green, and then we've got their operating margin down below in red. And this was done in 2019. So it was defining the difference between fiscal year 18 and fiscal year 19, and then projecting this out. If you guys sustained this kind of performance, you'd be operating in a negative margin by fiscal year 22. And this was a place that was operating at about 8%, way better than kind of the normal hospital or health system that we're seeing over the last 10 or 15 years. So they had a little bit of room and flexibility, but it was meant as a bit of a warning cry to say, if we don't figure out how to manage cost and manage payers in a way that's different, you're going to be operating in a negative margin in a matter of a couple of years. So real quickly, we can go to the next slide, Carla. How were kind of expenses defined for this particular health system? So salary and wages made up a huge chunk of that, as they always do. Benefits make up a huge chunk of that, as they always do. The biggest thing that we saw a huge increase, and it led to a critical discussion, was supplies. No conformity or standardability when it came to supplies. A lot of opening up supplies, not using them, and so really just a lot of waste in supplies, and I would say a lot of waste in purchase services as well. You can't really control depreciation and amortization. Like that's pretty much out of there. Professional fees, that's what you're paying docs and stuff like that. That's not doing anything but probably going up, and you could argue, I think it probably could and should. The two areas that we saw the biggest opportunity were in medical supplies and purchase service. And purchase services, think of it as any vendor that you use to supply a service that is being done on behalf of your hospital or health system that you're not doing yourself. Like cafeterias are typically run by a third party. The actual, that's a purchase service. As a revenue cycle leader, I may have bad debt vendors who I work on a contingency rate for me who fall into purchase services. But those are the two areas where we saw kind of a little bit of lack of stewardship in terms of monitoring that and maintaining that. And so there was a plan put in place to standardize medical supplies that was going to have about a $40 million impact there. And I actually don't know how that ended up, but it was certainly an area of huge opportunity, as well as just examining vendors, examining those partners that you use. And some of those are absolutely necessary. I would say all of them, all the services provided are probably absolutely necessary. It's just a matter of, can we do it at lower cost or can we do it internally? So that's kind of expenses for this case study we just talked about. Next slide, Carla. So an area that I like to delve into, because I do think it's really, really important as we talk about revenue cycle, we talk about denials, we talk about deductions, we talk about payer behavior. This was the most recent study put out by CMS on healthcare spending. And on the left, it's that we spent $4.4 billion on healthcare in 2022, and where did it go? And you can see that it goes to hospital care, it goes to physician services. You can kind of see the cut of the pie as to where $4.4 billion goes. Now, healthcare it's come back a little bit since COVID, but it's running around 20% of our GDP, which means that 20 cents of every dollar spent in this country in some way, shape, or form goes to healthcare. I think it's interesting to just kind of examine that on the left there and say, whoa, like here is where the money's being spent. As a revenue cycle operator, the slide on the right is of particular probably even interest to me as well, which is who pays the bill. Of this $4.4 billion, who's kind of paying the bill? So we know that government is our biggest payer, Medicare and Medicaid, but you can see that actually private health care is the largest spender. And it's why as a revenue cycle leader, I say, again, no patient is more important than any other patient. We're going to take care of everybody as if they're our only patient, but there are payers that I have to watch. This is a visual example of why private commercial health insurance is where people like I keep our eye on the most. Medicare and Medicaid certainly make up the bigger pie in terms of payer mix, in terms of people coming in with Medicare and Medicaid, but commercial insurance is the thing that drives profit margin inside of hospitals and health systems. If they don't behave the way they need to behave, and if they don't represent a statistically relevant part of our payer mix, we can see profits decline and go off a cliff in a hurry. And the other ones are government or other health insurance. TPL will fall third-party liability. If I use any acronyms that people don't understand, please, you can hold me accountable in the Q&A. And then there's out-of-pocket. This out-of-pocket one is very, very interesting to me as someone who's been in the industry for 20 plus years. That out-of-pocket used to run around 4%. This is the amount of money that we expect to get from the patients themselves, not the patient's insurance. But out-of-pocket, even like 15 years ago, used to run closer to 4%, 5%. It's now at 10%, which means that we've now exposed 5% of our revenue to a lot more risk. Commercial's a risk, government's a risk, but getting money from beneficiaries or the uninsured is a much larger risk than trying to get money from their insurance companies. And it's just because, one, I think they're experiencing more burden than they ever have before, and there's not really anything other than collections and all the other good faith efforts that hopefully go into trying to collect money from our customers and our patients. But that means that we've just taken on 5% in a sense more risk than we did 15 years ago as well, because that's a lot harder money to collect, even though it feels like probably in all of our jobs that commercial money is very hard to collect. But just to give you a view into the way I lens things, commercial is the most important thing to our overall viability. Balance after insurance, self-pay, that 10% I'm just talking about that represents the biggest risk associated with it because it's not collected on at a very high level. So I think we got one more slide here, and it's just to kind of talk about denials trends. And I'm going to hit my mark because I was so worried that I wasn't going to leave time for Q&A. So this is just some trends that we're seeing. Is denials have increased by roughly 3%, 2 to 3% over just the last 4 years alone. This is first pass denials. This is I submitted a claim, I expected to get paid, and I didn't. You denied those at a 10% rate 4 years ago. You're now denying them at closer to 13%. That means 3% of my AR, in a sense, my government AR or commercial AR is now requiring rework. And 3% might not seem like a lot. But if you look at it, it used to be 10%. That means 30% more rework than we were doing just 4 years ago, right? And it's why it's so important that record integrity is at the core of revenue cycle. I know that we want to collect money, and that's what people think revenue cycle is, but the record is the most important thing I have, and I would argue that it's revenue cycle's number one job is to maintain record integrity. Denial trends, 90 plus AR. So as a revenue cycle person, we tend to think of AR in these 30-day buckets. 0 to 30, there's DNFB, there's 0 to 30, 30 to 60, 60 to 90. After 90, as an AR professional, as a revenue cycle leader, I start to get really worried because I know that the time value of an account that ages past 90 starts to plummet very, very significantly. When I have not been paid in 3 months post discharge, I know that this becomes very, very risky, and it's why we measure things like AR greater than 90. So what this measurement here is to say that has went from 19 to 36% for Medicare Advantage plans. It went from 27 to 36% for commercial plans. All this saying is that payers are not paying us as timely as they used to. And there are a lot of reasons why that. We won't get into all that. Maybe that'll be, revenue cycle 102. But also Medicare Advantage has posed a really, I don't know, kind of fulcrum point I'm finding in the last few years, in that you've got a population that I used to be able to predict. Medicare is very predictable. They don't deny near as much as commercial. Their burden of proofs are pretty black and white. They're going to pay you in 14 days if you submit a clean claim, almost on the dot. But now you've got over half of Medicare being run like commercial. And it's created this entirely different volatile playing field where the payer that I used to be able to trust and predict the best, and also it was my biggest payer in terms of overall charges, is now acting half the time more like commercial. That's a ton of volatility and unpredictability into the AR space that hospitals and health systems across the country are struggling with in a very, very big way. Obviously, I talked a little bit about patient portion. When we get denials from payers, all it does is elongate our ability to try to reasonably collect from patients as well. And I think it's very human nature to say that, wait, you're now asking me to pay a claim from 8 months ago? You haven't asked me, like, what is going on here? And it's like, yeah, sorry, it took 8 months to get insurance to pay you, but that doesn't build trust with patients. It doesn't build a lot of faith in the process with patients. And I think appropriately so, they push back and challenge as to why they are paying something that happened 8, 9, sometimes maybe even a year ago. But I will say, this is kind of a duh statement, or according to HFMA, 85% of denials can be avoided. Yes, to the extent that I think payers behave in a predictable way, which they're not right now. They're, in the last 4 to 5 years, kind of COVID beyond, I have seen the most kind of egregious, unpredictable payer behavior that I've ever seen in my career. And I've been doing this for over 20 years. And I think audits have kind of entered into, audits were a huge thing, back in like 2008, 2009, 2010, 2011, because they had just kind of been introduced. But now I think payers have figured out, we can both deny and audit. And so a claim that even gets denied and overturned can still be audited, potentially even down the road. Never mind whatever rules are in the contracts that you have that allow them to just come in and audit willy-nilly whatever they want. And so the point of these trends to me is that it's just added a ton of unpredictability, a ton of volatility, and it adds a lot of cost to trying to run a revenue cycle that every year is being told, cut costs and get me better outcomes. And I think that puts my contemporaries and all of you in this really, really tough spot of, I need to collect more, but you can't really invest because our margins aren't as good and revenue cycle needs to run more efficiently. And it's like, to the extent we can, but you also got to understand more work is coming in than ever. And so cutting costs while more volume is coming in and payers are acting more squirrely than ever, I think is this confluence of a really, really probably the toughest time I've ever seen in an industry that I find really, really, really tough. With that, I think I hit my mark for 15 minutes of questions. I am going to open the door to those, and I guess Carla, you'll administer all that.
Yeah, we'll ask Kristen and Natalie to monitor out the questions and pose the questions. Ryan, I want to thank you. I learned a lot. I always learn whenever I hear you speak. So thank you so much. I thought that was really interesting. That article that you just referenced a minute ago, about 85% of denials can be avoided by implementing processes from best practices. Yeah, I agree with you because I've been in this for a longer than you. Maybe back in the day, maybe 85% of denials, but there's such a large proportion of denials that are actually overturned, and it might take a while to get there.
Yeah.
Which, you know, but yeah,
I mean, I'll say this: HFMA does some great stuff, but they're sometimes they come up with metrics that I believe are very either hugely conservative or hugely not. And I think it goes to a thing I would say about benchmarking too. So one of the biggest benchmarks in revenue cycle is AR days, and it's just a silly, stupid benchmark, and that's my opinion. Just my one guy's personal opinion, not the industry's, because I can make AR days be whatever you want it to be. It can be 0 tomorrow. I just got to write off all my AR. But HFMA has benchmarks out there for AR days. I'm sorry, if you're high commercial, lower government, your AR days should be completely different than if you're high government, low commercial. Like the more government you have, the lower your AR target should be. The more self-pay you have, the higher your AR targets are going to be because it drastically inflates that kind of stuff. So again, they do some great work. I will just say that trust some of HFMA's numbers with a bit of a diluted lens.
yeah, interesting. Thank you.
Yeah.
Okay, Natalie and Kristen, do we have some questions for Ryan?
We have a few questions. I'll go ahead and start with the first
one. Can you
Natalie,
speak?
Yeah, thank you.
Oh, there you go. Can you hear me better now?
So much better. Thank you.
Okay, great. All right, I will go ahead and start with the first question. Is it more beneficial to share denial data and work towards a mutual acceptable rate rather than working single appeals, which is not working?
More beneficial to share denials data. Can you read that after that one more time?
To share denial data and work towards a mutual acceptable rate rather than working single appeals.
I'm assuming they're talking about like with payers, or are they talking about, I know you can't ask the question, but I'm going to try to answer that as best I can. So there are collaboratives out there where they're trying to share payer behavior data to create a little bit more critical mass to kind of say, if a payer is exhibited egregiously across a statistically relevant geographic area or whatever, then do we then have more horsepower to fight them? Yes, I think hospitals and health systems should collaborate a lot more on sharing denials data, if that's the question, because I think it gives us more of a vehicle to come at payers in mass and in more of a unified force. And that's something that we've never really done in the past. But I think there's some things emerging right now, and certainly Payer Watch is one of them, where they're trying to kind of come at payer data to examine behavior, predictability, use algorithmic data to try to say if this fiscal intermediary is acting this way, but this one's not, then we can probably expect that this one's going to start acting that way pretty soon. Or if Medicare, we see some trend in Medicare, the commercial is going to be on their coattail pretty short. I don't know if that was the exact question, and if it wasn't, feel free to try to clarify it for me. I apologize if not.
Great. Okay, I'll go ahead and move to the next. Where do you fit the Medicare Advantage plan in this spreadsheet? Are they lumped in with Blue Cross? If it's Medicare Advantage Blue Cross plan, or is it lumped in with Medicare?
So typically, I've seen both is my answer, but most typically I see them in Medicare. I don't know that I am a huge advocate one way or the other. And I think the reason they are lumped into Medicare is because they're typically supposed to kind of pay according to those standards. I think you could argue that you could lump them into their own category. I've seen people do that too. I do think that potentially does give you more laser focus onto just exactly how they are behaving. The problem is you've got these multiple players in there, much like commercial other in that graph that I showed earlier. And you just got to have clean ways to make sure that you can aggregate and pull data to kind of understand that. So if you want my opinion, what I've seen is mostly it's Medicare. Mostly they get lumped into Medicare. I would probably be an advocate of creating my own payer mix called Medicare Advantage, because they act wholly different than traditional Medicare.
Great. Thank you. The next question is, when you say private health insurance's largest payer, are you adding Medicare Advantage plan spending to the commercial spending?
No, I don't. I don't include Medicare. I don't include Medicare Advantage in it because of the way they reimburse. The reason I keep commercial, what I often call commercial other, and Blue Cross as my commercial bucket, and the only reason people keep Blue Cross separately is because it typically represents the largest commercial payer by quite a bit. And so the reason people keep it differently is to just understand what Blue Cross is doing easier than understanding what if they were lumped in with commercial. But no, I don't lump them in because of the way they reimburse. Commercial/private insurance is so important because of the way it reimburses, which is typically 3 times Medicare.
Okay, our next question is going to be, denials related to prior authorization issues seem close to impossible to overturn. Are there points to hit to improve outcomes in this case?
So I think part of the problem with prior auth is, again, when you go back to CARCs and RARCs, like they're not universally used. It is going to be very, very hard to get a prior auth overturned if you asked something that wasn't actually performed. That's going to be like almost impossible. I think the key to trying to win prior auths is understanding what the procedure was. Does it have a high variability of kind of complication to it, right? So a lot of times you might auth something, the procedure starts as that, the procedure ends as something different, or other things are done once you've opened up a patient. And those kinds are a lot easier. And I think that's about where you have to be able to reference good, solid clinical research, relevant, solid clinical research, as well as the law. I'm a huge proponent of, and if this is you, please understand that my next comments are not an indictment. But one of the things that I did my whole career when I was running revenue cycles is, my auditors, my physician advisors, my follow-up reps, they had a SharePoint folder where they'd go and they'd pick out a document, and that's how they were going to use to fight it. And it wins sometimes, and it doesn't win sometimes. But I think being able to supplement any argument with clinical research that's relevant to the case and can be referenced, and the legal argument that's relevant and referenced are your 2 best ways to try to overturn a prior auth that was done in best faith. I mean, that's one of the legal arguments you can make is, that, I mean, there's laws that say, like, when you go do something in best faith, that if that changes because of your clinical expertise, then actually you're all 100% well within your rights to do that. And so prior auth is tricky. And I would just say that if you auth something that's just not going to get overturned, or you auth something wrong, just let it go. I know that's hard, but all it does is just add to AR that you're not going to get liquid, and it turns into work that people have to go research. So the best thing I can tell you is strong clinical arguments relevant to that particular continuum of care, and strong legal arguments as it relates to that particular continuum of clinical care.
Ryan, if I could just add, you made a statement about articles or references that can be accessed. I think that's a really good point, because sometimes links break or something is out of date. So you send something, make sure that the recipient is able to click on it and go where it is that you want them to be able to go. Yeah.
And I think, and it can be hard, because the summary plan benefit is always a bit of a needle in a haystack sometimes. But understanding the summary plan benefits for that particular payer, understanding the particular policies they have related to that particular kind of procedure or continuum of care are important, and being able to reference them. We just overturned something recently that was the policy was outdated by 4 years, and we had clinical research that said there's a September study from last year that's more relevant. That's what you need to be using.
Great. The next question is going to be, what are your thoughts on utilizing AI to work denials and write appeal letters?
I'm surprised it took 4 questions for this to come up. So
yeah.
There was a great article in Becker's, I think it was yesterday, maybe the day before, about how both beneficial and terrifying I think AI can be. Yes, I absolutely think AI is incredibly beneficial for things like if this then type stuff. I think it can be beneficial for templating certain appeals, as long as, again, you can tie that to the clinical and legal research that needs to accompany a really solid and good appeal. I worry. So I had adopted AI. It's really RPA. I mean, AI is kind of a bastardized term, but a lot of what they're talking about is RPA, robotic process automation. So I had adopted it back in like 2015, but I was using it to write rules to say, if payer denies this, we know that we just need to go add a modifier and then, and send out these without a human being having to touch them. And I do think that's the benefit of AI, is it can automate mundane, routine tasks that leave folks like I know that are on this call to work more up to their licensure. I don't think AI can replace, at least not in its current form, anything that the folks on here do, but I do think it can be used in a very supplementary way to create kind of if this then type stuff. And to the point I made earlier, boil to the top the kind of work that licensed clinical professionals need to be doing, if that makes sense. And I think same thing for revenue cycle folks, like my follow-up reps. I used to use that term all the time when I ran, a physician advisor group and the UR team, is I want you guys working up to your licensure, work up to your licensure. I don't want you doing mundane tasks. But the same thing goes for follow-up reps too. I don't want you going and researching an account that I know we're going to lose. So let's use AI for that kind of stuff to help kind of queue up smart work and help us alleviate some of the just kind of button pushing work, I guess, assembly line work. And let's leave the professionals that are on this call to do top of licensure.
Great. Our next question is going to be, what is your 3 best tips for documentation to help prevent denials? For example, many payers deny cases solely for the reason of 1 MCC or CC.
3 tips for documentation. So the first is, I need clinicians to understand that as much as they hate it, it's a really important part of their job. And I think that's the one I've run into the most, is it's not that people want to be crappy documenters. It's that it is seen, and rightfully so, by the way, it is seen as an overly burdensome technical activity that doesn't really help me take care of patients. And I would say, to some extent, yes, you're right. I would say that good documentation does, in fact, take care of patients. But I think clinicians have to take it seriously, and they have to understand that it's a part of their job. I mean, all of us have parts of our job that we hate, but we still have to deal with. And I've had this conversation with a lot of very, very reasonable doctors who get it. And I think, I do, I completely understand that I don't want to do this part of the job. It's keeping me from seeing patients. But this may be an inflammatory comment. So I've had this argument with docs a lot, but I believe, this is my personal belief, that the patient record belongs to the patient. There are doctors who believe it belongs to the hospital or it belongs to them, because I'm like, I just fundamentally disagree with that. And again, I'm not trying to start an argument here, but I believe that the record belongs to the patient. And if so, and if you were a patient, wouldn't you want the documentation to most accurately represent any continuum of care that you had? And I think when we start to look at it in that vein, we can start to say, yeah, it's burdensome, but it's important. So number one thing is clinicians have to care about it, and they have to not see it as this. They can see it as part of the job they hate, but they have to see it as a necessary part of their job. I think the second step is putting support and structure around those docs. So it's not punitive. It's not, you didn't do something, I'm querying you, and I'm trying to be a pain in your ass. Sorry, but pain in your butt. But I'm really here to make you a better documenter. And oh, by the way, when you're a better documenter, you are in fact a better quality doctor. Bad documenters are by all quality metrics bad doctors. And I'm not pointing fingers, I'm not trying to say that in a mean way. But the better document you are, the better documenter you are, the better your quality scores are going to be. I promise 100% of the time. Okay. So, but I think a lot of people get around doctors and make it punitive. And I've seen that too many times too, where it's like, it's not supportive. I don't think the majority of people want to be bad at their job. I think they want to be great at their job. But I think too many like CDI programs and those kind of programs can feel overly punitive and rigid, as opposed to at the elbow, really supportive. Let's buy into this together, and I will make it as easy as I possibly can, knowing full well that it's not really easy to change old habits, or to say it's very, very important that you spend 10 more minutes here, 5 more minutes here, even though you don't see it as important. So I think that would be my second thing, is create a very, very, very supportive environment around it. I would say my third thing around that is, kind of goes to supportive environment, but if you have a CMIO or a CNIO, however, like the EMR at your disposal, whether that's Epic, whether that's Oracle, whether that's Allscripts, whether that's Meditech, whatever it is, has to be built and maintained in a way to support you. And I'm not necessarily talking about templates or things like that. It's more of just intuitive stuff that I think EMRs are really, really bad at, in terms of boilerplate, here's how a physician's going to work in it. So I would say docs have to buy in, supportive environment around them, and then your IT department, the IT that supports your medical records, has to be right there at the elbow as well, trying to make this easier. One of the things I commonly say about EMRs is, and we have to collect a lot, we have to, regulatory-wise and compliance-wise, we have to collect a ton of data and report it to agencies that tell us that we have to report it to. So sometimes it's I think physicians think like, why do I have to collect this? Like, because I have to report it to the regulatory agency that's requesting it. It's not me. I wouldn't ask you to record it if I wasn't going to get fined as a hospital for not reporting it. And I think that's another thing to just kind of understand is EMRs have created this environment now, and this is regulatory agencies, not physicians, not hospitals, where because we can, we will. And I think that's a very dangerous environment. It's like, well, now that we have EMRs, we can get any data we want out of it. I'm like, yeah, but just because you can doesn't mean you need to. Like, more data is good in certain places, but just doing it for administrative burden, I think sometimes is silly. I have an example of that, but I'll save it.
Just from what you were just saying, in my previous life, we tried real hard to talk to the physicians with the idea of what's in it for them.
Right.
And not necessarily them personally, but them as far as their patients go. You know, if the attending, you know, falls sick and is not able to come in for a couple of days, he or she absolutely wants somebody else to be able to pick up right where they left off and know exactly what's going on, you know. So it does benefit the patients. Mm-hmm. It also, you know, it benefits the hospital. You know, surgeons want, and other docs, you know, they want rightfully so, the latest and the greatest. The equipment, nurses, assistants, all this takes money, you know, and there is a direct impact. And yeah, so just my 2 cents.
Thank you, Carla.
Are there any other questions? Oh, it's 3:05 already. Wow.
Time flies.
Yeah, it does. Yeah, it does. Brian, yeah, here's a references slide, you know, it'll be in your handout. We did the Q&A. And Brian, thank you so much. Such good information. I know I appreciate it. I'm sure our audience did too. And website there, info@adam.org, if you have any questions. And I think with that, we're going to close. And don't forget about our next webinar coming up. It's open for registration. So thank you all for attending and spending your time with us. It's much appreciated. So long.
Thank you, everyone.